Dr. Mumaneni gave a great introduction for our honored speaker, Dr. Christopher Shaffrey, professor of neurosurgery and orthopedic surgery from Duke University. We'll shift our talks a little bit. We did a lot of pediatric topics this morning, and Dr. Shaffrey will share with us kind of updates on pedicle subtraction osteotomy, surgical techniques, tips and pearls for us.
Thank you.
Thanks, Dr. Shaffrey.
Well, this is a little bit, even in pediatric patients, if they've been previously fused, the pedicle subtraction or three-column osteotomy is something that can be utilized. So one of the things is that that a lot of us years ago were a lot less attentive as far as how spinal alignment, where we achieved it and where we placed it and how it impacted people. And this is a case that was sent to me years ago, and they went and they did a decompression for quote spinal stenosis and ended up with a teetotal disaster. And so if you have something that you do an adequate decompression, or even you fuse an area of instability, it's really critical that we achieve physiological and appropriate alignment. And a little bit of what I'm going to get into this talk about is, I think our views of even pedicle subtraction osteotomy have changed about where we do it and how we do it, and are there other alternatives in some cases that may result in a better functioning spine. So this is somebody here who had a couple operations, and this was the first one was done. The lateral one was done for idiopathic scoliosis at kind of the end of teenage years, and then had increasing pain in the thoracic spine, and then had this surgery done. And now, as we saw, in one of the cases yesterday, that when you're 18 years old, you can basically physiologically handle sometimes, a pelvic tilt of 40 degrees. But when you get older and all of us become a little bit more deconditioned, the ability to be able to, to handle a high pelvic tilt becomes increasingly bad, and people fatigue and pitch forward and have other problems. And so you can see here with this osteotomy that it did result in a big change in a much more physiological restoration of alignment. You can see the pelvic tilt here is 14. So there are a lot of different options. I think tomorrow someone's speaking about the majority of them, and what I'm just focusing in on is the pedicle subtraction osteotomy and its variance. And because, depending on how much, whether you remove the superior end plate and you take out the superior disc, I think a lot of people are grouping this into what's called a three-column osteotomy, because sometimes the difference between pedicle subtraction osteotomy and a vertebral column resection gets to be somewhat nuanced. So the advantage of the pedicle subtraction osteotomy is, depending on how you do it and your technical skill with it, you can generally get between 25 and 35 degrees per level compared to some of the other different osteotomy types. And again, if you remove the superior end plate, it's probably more predictably in the 30 to 35 degree range. And if you do a full vertebral column resection, you can get up to about 50 degrees of correction with this. Now, the factors about doing osteotomies are multiple, including the magnitude of the deformity, where it's located, whether it's flexible, rigid, fused, and whether someone has had previous surgical procedures. These are all factors to do it. And one of the things is sort of the spinopelvic alignment, particularly for the location of the pedicle subtraction osteotomy. So one of the things where I try to decide, hey, is there any way that I can get by without doing a pedicle subtraction osteotomy? I have a tendency to use dynamic radiographs. In general, if you have less than 5 degrees of motion through the lumbar spine, that's kind of a fixed spine, and if your appearance on the CT scan shows that segments are fused, then that really pushes you into this kind of three-column osteotomy role. So this was a flexibility categorization by Larry Lenke, And what he says is type C, which are the fixed, stuck, fused, are the ones that pedicle subtraction osteotomy are most for. So the case here just shows you by an upright position versus being supine versus being positioned on a Jackson type frame, and then with multiple posterior column osteotomies, you can see the change in alignment that you can get, and something that you might have, that I might have said 10 years ago needed a pedicle subtraction osteotomy. Now you can get by with multiple posterior column osteotomies with less blood loss and less potential complications. This is another case of mine. And again, you can see a very significant spinal deformity, but with positioning with multiple posterior column osteotomies, you can see that there's a much more physiological restoration that was done. And again, years ago, I probably would have done a VCR at the apex of the kyphosis instead of working sequentially through each of the levels. And as I said, each of these big osteotomies, the 3-column osteotomies, have risks of complications, as you'll see. So basically, this is sort of the pedicle subtraction osteotomy technique, and it goes, and you can see the removal of the posterior elements. And with the screws in, this is a traditional pedicle subtraction osteotomy. And by closing those down, that's how you get the 25 degrees of lordosis from occurring. And again, with this change, you can see how you can get, particularly as you work lower in the spine, an enormous correction of sagittal vertical axis and other different parameters. So this is Frank Schwab's classification of spine destabilization. And the key for almost every corrective maneuver that we do is to stabilize the spine to some degree to allow us to apply corrective forces to have it better aligned. So we start off with a partial facet joint resection, then a complete facet joint resection, and then a partial vertebral body resection, and then the partial plus a disc, which some people call an extended pedicle subtraction osteotomy. And then finally, the vertebral column resection, where both discs, both end plates are removed with that. So this is the classic pedicle subtraction osteotomy. Generally, it's used when more than 20 degrees of segmental correction is needed. And again, showing this correction. And this is kind of was a typical case. Somebody who had multiple previous lumbar fusions. And I want you to note something that there's been a number of papers put out, and particularly from when I was at UVA, about lots and lots and lots of pedicle subtraction osteotomy cases. And back 15 or 20 years ago, most of my pedicle subtraction osteotomy cases were done at L2 and L3. And there's some real downside of that. That's not physiological. There is a lot of risk of PJK if you don't exactly get the alignment of the spine right. And part of the problem is that particularly for people who have a lower pelvic incidence, that it really does not have, it has actually negative implications as far as spinal pelvic alignment. So you really have a very hard time getting any noticeable change in pelvic tilt, which is how much your body is compensating for a mid-lumbar pedicle subtraction osteotomy, compared with getting the correction lower in the spine. And I said the lower the pelvic incidence, the more this holds true, as I'm going to show you in a minute. So you can do an asymmetrical pedicle subtraction osteotomy where you can correct both coronal and sagittal malalignment. You can see this person here is coronally imbalanced to the right side and severely sagittally imbalanced. And after this pedicle subtraction osteotomy, the correction is satisfactory in both planes. What's happening is increasingly, when we need to get bigger correction, we remove the superior end plate and the disc. That also has the advantage of two bony surfaces abutting each other without that intervening disc, which has the potential of reducing pseudarthrosis and rod fracture rates. And you can see here, this is again someone with multiple different fusion procedures and the superior end plate being removed to realign the spine with that. And as again, if you remove the entirety of the vertebral body, classic 3-column osteotomy, and again, this is a person that had idiopathic scoliosis, had the instrumentation in the thoracic spine removed, then had a fusion down into the lumbar area, and the overall alignment was less than ideal. And to go and to correct this, I resected the vertebral body at the apex of the lumbar deformity to do that. Now, one of the problems is, who really needs a PSO? And basically, one of the issues is Medicare began looking at a lot of the different spine codes. They found that, quote, a PSO was being done in an extraordinarily and increasing rate. And the fact is that, that probably a lot of this it may have been more kind of money driven, and a lot of people that I would come in and get an op report and said, oh yeah, I had a pedicle subtraction osteotomy at L3, and I kind of look and the L3 pedicles are still there, so I sort of wonder what exactly was done. So some of this may have been true coding or billing versus truly the need for this. And and one of the things is this was a patient that was sent to me saying, hey, this patient needs a PSO, and they were sent for me to do the PSO. And if you look here, the dynamic films, and more importantly, the CT scan shows that there is vacuum within each of the disc spaces. And when you have something like that, it really makes it that you can do posterior column osteotomies, or, I do some aggressive T-lifts to be able to go and to restore the motion, in the lumbar spine, and to have it in a more physiological location. So what's happening is, it's not a perfect operation. The complication rates are high. For any of us, that spends hours sort of digging through the scar tissue surrounding the dura to peel all of that off, knows that it can be a kind of a trying operation as you're trying. The scar tissue is probably, it's like 10 times the tensile strength of the dura. So as you're sitting there with me with an 11 blade, slowly peeling the scar tissue off, you sometimes wonder, isn't there an easier way? I kind of think, boy, I wish I was Praveen and I could just go do some little thing through a tube at the end of a PSO day. So one of the problems with this is paper after paper after paper say that undercorrection is really common with pedicle subtraction osteotomies. The lordosis provided is usually not physiological if the PSO is above L4. So most of the lordosis in the lumbar spine should be between L4 and S1, not at L2 or L3. And what's happening is that people will end up having compensatory mechanisms, including the development of thoracic kyphosis over time, particularly if the alignment is not physiologic. So these operations are kind of fraught with complications. This is some work from the ISSG looking at 3-column osteotomies, and if you can see there, we had, and these are some fairly experienced surgeons, we had about an 80% complication rate when you looked at all comers. So these are not something to do lightly. And one of the things, is that I think there's some misunderstanding or misbelief of what our capabilities are. And what happens is, many of us think, oh, just because it was written, that you can get 35 degrees of correction by doing a pedicle subtraction osteotomy. That is some very rare individuals, and a lot of times, again, this undercorrection results in significant problems with realignment. Even if you do a very good job, there's complications that occur, up to 3 to 5 years afterwards. The most common one is rod fracture. One of the, this paper is looking at my cases, and I put this up there. If you see there, this was looking at over 100 PSOs, And if you see there, at this time, the majority of the PSOs I did were at L3, some at L2, and a couple at L4 back when this was written, and I think it was 2018. So the fact is that these are some things that I've had to learn through the hard way through my own mistakes. And this is one of my patients, and you can see there, the PJK that's developed, the really non-physiologic lordosis. You can see that the pelvic tilt is almost 40 in this patient. And even though they were standing up, quote unquote, better, the reality was it was a setup for failure. And you can see the eventual the surgery that I had to do, including a VCR to be able to go and try to get it better. And even with this person, they're still at some risk because the lower lumbar spine is still in a non-physiologic location. Now, if you look there, you see a couple of I think they were Ray fusion cages, and the patient had a pseudomeningocele, and to be honest with you, I probably was lazy at that time and just did not do what the right thing to do. So basically, sometimes you have to do more. Sometimes you have to combine the pedicle traction osteotomy with either hyperlordotic ALIFs or other things to be able to go and to get the correction. So one of the things which we are increasingly recognizing, and this is from Professor Rousselet, is where the apex of the lumbar lordosis physiologically should be. And people who have a low pelvic incidence, the physiologic apex should probably be somewhere between L4 and L5. And as you have a higher pelvic incidence, the apex can drift up to even the L3 level. But again, L3 is for people with a very high, a 80 degree pelvic incidence for it to be in that location. So for most people, really, what's physiologic is probably at the L4 level for the majority of them. And this is some work. That was done through the ISSG, and again dictating that somewhere around 60% of your lumbar lordosis should be between L4 and S1. And you can see across the pelvic incident ranges that somewhere at L4 is probably the most physiological level if you're going to have to sort of pick one to be able to do. So this is another study looking at the radiographic and clinical outcomes for L4 and L5 pedicle traction osteotomies. And the reality of it is that this is where it's done, and the results of pedicle traction osteotomy done at these levels are far better than when they're done more proximally in the lumbar spine. And this has been confirmed. This is some work from the ESSG showing the importance of the gap score. And if you have a physiological apex at the right location, the risk of mechanical failures, particularly PJK and other issues, are far lower. So it's really important to get your lordosis into the correct level. So basically, the reasons for failure to get great alignment is failure to understand where the physiologic apex lies. It's poor preoperative planning. It's poor surgical execution. And again, there are some times, like the case I showed you, where they had the pseudomeningocele, that it just can be just an absolute bear to do things at the appropriate level. And that's why I think that, as was discussed yesterday in a couple of cases, the move towards doing hyperlordotic ALIFs is really something that is oftentimes a superior alternative than try to slog through a lot of scar tissue. So basically, this is sort of an example here of somebody who's had a previous fusion, and you can see that vacuum disc. And so again, this is a case where I put a hyperlordotic ALIF in, and then basically stood the person up. And suddenly I said, that correction is quite good, and spared this person from a pedicle traction osteotomy compared to, kind of a bear of a revision surgery. And these are several different studies looking at the advantage of hyperlordotic ALIFs to be able to go and restore adequate sagittal alignment. Now, one of the things which I find amusing is at my place there are a lot of people who do minimally invasive spine surgery. And they're writing a paper right now on their series of 22 patients who have had an L1-2 anterior column release to, quote, correct their problems with the physiological lordosis. And it's funny, every time for minimally invasive surgery, they say, oh, because it's minimally invasive and you don't disrupt as much the muscular envelope, we can get by with things that wouldn't work in an open surgery. And this is actually one of the patients that was done at done at Duke, and I just wonder that an L1-2 apex of lordosis, whether that is really going to be the advance that we think it's going to be. So I think one of the last things is the PSOs. When I see somebody at our institution when they've got a PSO posted, an 82-year-old, I oftentimes kind of wonder why. Usually there's something else that you can do to get that bit of more lordosis that you need to treat that condition. This just shows you with the red box, what the parameters are that you can get by with a fair amount of SVA and PILL mismatch, for those people that are 80 years old. So we talked about the rod fractures. They're pretty common with PSOs, and the question to do it is the use of multiple rods. If you see the 4S, the one with the satellite rods, in the ISSG experience, there has never been a rod fracture or a pseudarthrosis in the cases where you have this deep-seated rod with the spanning rod passed over it. And that's something which I do now for the majority of my pedicle subtraction osteotomies with that. So basically, just to summarize, the flexibility is the key. If you have some flexibility, don't do a pedicle subtraction osteotomy. There are better choices. The location of the physiological lordosis is really important. For most people, that apex of lordosis is L4, or sometimes with people with very low pelvic incidence, it's L5. But an L4 pedicle subtraction osteotomy is pretty safe and usually gives good results. And by doing that, you're going to have a lot less failures and a lot less revision surgery. Thank you. Praveen.
Chris, I think worry when we do an L4 PSO that we get a higher risk of foot drop. Say and I talked about that, we end up doing a big L3, try to stay away from that 5 group inside the split brain. What do you think of that?
I think it's more challenging. I've had a couple foot drops doing L5 PSOs. I think they're actually part of it is the sort of the ligamentous attachments to L5 to the transverse process makes it a bit more difficult. The vertebral body is bigger, and I have more trouble with the L5 ones. So a lot of times I find it's easier to do an S1, a superior sacral osteotomy, than doing L5. So I'll do 4, and to this point, probably have done 30 of them. And I may have somebody who has some transient weakness, but I say this and it'll happen in the next case I do, but I have not had like a permanent foot drop with it. But I have a lot of people, even at L3, that'll have, some, quadriceps, they have a limp and they're limping around, and I usually say, yeah, it'll eventually get better. But the fact is that as we've shown and SIG really showed with the scoliosis wrist stuff, about 1 in 3 people will have a significant neurological deficit, usually a root level deficit related to 3-column osteotomy. So it is a common thing to have, and that's why, pardon me, hyperlordotic ALIFs, although we had a case last week at Duke of somebody doing two 30-degree ALIFs at 4.5 and 5.1, and the patient woke up with bilateral foot drops. So you can even, I think, overstretch that in cases too. So that's not completely protective.
Do you have a sense for what size cage can give you a bilateral foot drop with an ALIF is one question. And just, you were also showing those cases with an ACR at L1-2 and trying to restore lordosis. I haven't done a lot of those, but the ones I've done have all PJK'd. And especially if the patient has a high BMI, they tend to PJK pretty quick.
Yeah, I just don't like the way the post-op X-rays look, and that's when we have a indications conference, and we show kind of our next week's big cases and then the follow-up for the next week's big cases, and I just look at the L1-2 ACRs and say, boy, that just doesn't look right, and it'll be interesting to see what the long-term results are. Sig, I see you've gotten up and.
First of all, terrific overviews. I always learn so much from your experience and insights. I think, Praveen, your point about the ACRs, I share your criticism about getting the apex of lordosis right. I think Rousselet's classification is really important. And, the ACRs are rarely done below L4, right? Typically it's a 3-4 or 2-3, and that observation of PJK, I think, Praveen, you and I have shared a couple of those cases, and I've definitely moved away from that. After a TLIF, so often TLIFs just aren't creating a lot of lordosis. So a lot of my PSOs recently have had prior TLIFs from 4-1. Now they're flat from 4-1. You described how difficult it is. The difference in the durability of the dura compared to the scar. Any advice on what you do after a TLIF? Do you ever? Any advice on that?
Yeah, it's just painful to pick the scar tissue off, and and where a lot of the issue is ventrally, because you'll get some of that ventral scar tissue that keeps under there, and you don't want to go and do it. Now, the only positive thing is unlike a lot of other stuff, when you really close that down, it causes some dural redundancy. And they don't seem to leak quite as much that if you just did it with the dura being tense. And it's weird, for the neurosurgeons here, we'd go take spinal cord tumors out and open the dura all the time, and they never seem to have a problem. It's somehow some configuration when you have kind of a little tear and it just seems to leak more. So the good news is that the PSOs in general, it closes. The problem is that if you herniate a couple nerve roots out, I think there's some of the people that have this terrible radicular pain and whatnot. So I've, in some cases, if I get a ventral tear, I'll take a piece of Duragen or whatever the dural replacement you like, and I'll make a tube around it and put a couple stitches into the posterior dura to hold that in place to make sure you don't get that kind of an egress. But it's a bear, and it's funny because I think that as you get older, you get a little bit smarter and maybe a little bit more cautious. But some of the stuff I'll look at and say, oh my goodness, I don't feel like spending 3 or 4 hours peeling the scar tissue away. And I'll tell you, that's, for me, like bending rods and having, peeling scar tissue are the two things that for fellows are you watch them do it and you're like, hey, it's getting a little thick. Oh, suddenly there's a gap in the dura, and you're thinking to yourself, there goes another 2 hours of time. So it is something that is painful to do, and that's why I'm one of the people who would love to have this kind of ACR thing work better and whatnot, just to be able to go and send that to send a couple of these cases to my partners. I just don't think it does well enough. The hyperlordotic ALIFs is you got a big vacuum you have a hyperlordotic ALIF. I think you had asked about the size of the cage. I think that you need to have, one of the problems when you get up to these like 30-degree cages, it's like a wedge, okay? And I think if you do that and you do Smith-Pete's at the back, you can close that foramen down. But if you over distract, particularly if they've had previous surgery, I think you can put traction on the nerve root for over distracting as well. So for me, if it seems to come pretty easily, I've not had a problem. Where I have problems is if you're pounding that thing in or pounding your trial in to get correction, I think that's where you either you stretch the nerve root or you do something that impacts the nerve root. You do so many of these. Say, what are your lessons with that?
Yeah, I think the postoperative radiculopathy after an ALIF is a real problem, and I think it's a bit of a paradox because with the hyperlordotic cages, I think exactly what you're describing. The hyperlordotic cages tend to be 4 millimeters posteriorly, and I think if you've got less than 6 millimeters of posterior height, you're going to create foraminal stenosis, especially if you do that posterior Smith-Pete over it. And I think a lot of times the hyperlordotic cages combined with the Smith-Pete is foraminal narrowing. But then the other end of the spectrum is if you get more than 8 millimeters posterior height, especially in a revision setting, I think that's exactly what you're describing too, is you put a little stretch on the nerve roots. And the TBI guys actually showed that in some of their post-laminectomy ALIFs, that when they had more than 8 millimeters posterior height, they had a 30% incidence of postoperative radiculopathy. Most of them got better, but I think paying attention to posterior height is really critical.
So let me ask you. I was last week in Zurich. I get a call at like 2 o'clock in the morning, and one of my partners had done a case and done 2 25 or 30 degree cages, but had really pounded them in to try to get the posterior height big enough. And the patient woke up with bilateral foot drops and progressed to the next morning to not being able to move, no dorsiflexion, no toe movement, no anything. And he said, what should I do? Should I go in and take the cages out? Should I go and do foraminotomies at both levels? Or do you think this thing is going to get better? And I said, well, I might consider taking the cages out and doing a little bit less. I don't think it's going to immediately turn the problem around, but you've probably overdone it a bit. And then he said, well, we had a pretty big venous tear, and and he put put screws, interfixated, cage with the screws in. And suddenly I said, maybe I would just go and pray and just hope that it goes and gets better. So the people that I've had who have had weakness, had some movement, but weak, they have all gotten better. But for anything, it's like a C5 nerve root palsy. If it is out completely, okay, I'm not sure what the prognosis is. I think that they do not seem to respond the same way. Do any of you guys have insights? Say, what would you have told the person that had the 2 cages in? Would you have taken them out? What would you have done?
It's always different when somebody's asking you versus when you've got to do it as well, right? Your recommendation might be different. But, honestly, on that, I would take a real close look at a CT scan and see whether it's a foraminal narrowing issue or whether it's more of a nerve root stretch. Again, with the hyperlordotic cages, I think it's a foraminal narrowing issue. So I'd go in the back and just do complete facetectomies in the back would be my typical approach for that. I've definitely seen people with postoperative radiculopathy where we've gone and decompressed and they've gotten quite a bit better. But I would deal with that from the back rather than trying to do something from the front, I think.
Dr. Shaffrey, great talk. And I think, I've seen and talked to a couple of people from New York, they've seen this too, is that sometimes you have that osteophyte hook, behind, right at the foramen. And despite that, you increase the height, that hook, bony hook, kind of lifts the nerve root up still. Have you seen that? And in those circumstances, what do you prefer to do?
I have not had it happen, but I've seen it. And in those cases, it's usually I'll do something where I'll do back, front, back. So I'll put the screws in, I'll do the decompressions, which allows me, I think, to get a bit more mobility from the front anyway, and then flip them over and drop the rod in. And I say that, and I probably should do that more than what I do it, because again, for me, a front back operation like that is an all full day to get that done, at least in our system. It's funny because you finish the back part and then suddenly everybody seems to go to lunch and you're there by yourself trying to flip the patient and reposition them and do that. And then at the end of the day, everybody's gone and, as I think that, that's what I typically do now is to go, or I would tell you I would do it. What about yourself?
Yeah, I mean, I'm a TLIF guy. I agree with Sig that a lot of TLIFs are kind of kyphogenic. I think it's depends on the technique, also what implant you use. If it's a straight, flat bullet cage, you put it in there, it's going to be flat. But I think, if you do PCOs and have a banana cage in front and compress down, you can get it. And now, newer expandable cages, even through a minimally invasive approach, you can restore enough lordosis. By far, I mean, I'm not saying that TLIF can beat the ALIF in lordosis restoration, but in a lot of cases, they can't get enough.
Well, I do, as Sig knows, I do about 95% of what I do is TLIFs, okay? And I can get at L5S1 with like a vacuum disc, I can get about 25 degrees of lordosis by taking both facet joints off and distracting and I put some pretty big cages in and then compress in that area. And I can get about, it's at 20, 25 degrees, but I can't get more than that. And that's why I can get 30 or 35 when I do, and what happens is you'll do the front and I usually put just one single screw in. And when you take the facet joints off in the back and you position them, there's a gap, a cage that was really tight in there. That cage, that becomes an issue. But I've even had that, despite me doing an aggressive decompression, with that hyperlordosis, it still narrows the foramen to a degree where I've had people who've had a radiculopathy after me doing that. So, I mean, you can really overdo it. But I'm just telling you, having a bit of a radiculopathy is better than having somebody have a foot drop for an L4 PSO or, significant, quadriceps weakness for an L3 PSO. And I've had both of those happen.
Chris, one more question about the spectrum from extended PSO to a VCR. So a patient who you showed a nice case, a real wedge fracture from either osteoporosis or PJK. When do you just go ahead and level that out, create sort of a vertebral plana by taking out the pedicles? And when do you go ahead and do the complete VCR and kind of reconstruct the anterior column?
So the real issue, so I probably need to show a couple cases to update this. So what a lot of times I'm doing now is I'm T-lifting the bottom disc. So if I'm doing an L4 pedicle subtraction osteotomy, I'll T-lift L4-5, okay? And that way I can be very aggressive with my L4 PSO. I can do sort of an 80% VCR and have that fit on it. And the problem is trying to do a VCR in the lumbar spine is trying to get that inferior disc out if you haven't planned for it. Superior disc is easy, it's relatively easy. But trying to get that inferior disc out is a bear. So because of that, if I'm gonna need, kind of 40 degrees, I T-lift, usually 4 or 5, and then do kind of an 80% vertebral body resection. And if you do that, you can get approaching 40 degrees of correction. In the thoracic spine, clearly it's easy to go do that, but I just cannot, get that inferior disc out. And there's some kind of, there was some kind of, I saw a presentation that I caught kind of the last half for the Seattle Science Foundation, and Jens Chapman is doing something like he calls it like a reverse PSO, where he's taking out the inferior disc. And Jens is a very, very talented surgeon, but I don't know how you do that. I don't know if any of you guys have got some clear insights, but for me, trying to get that inferior disc out and not stretch the nerve roots or do something like that is a bear. That's why I've been T-lifting that bottom level. Sig, can you take that?
Well, Jens is talking about is that T-PLIF is what he's actually doing is releasing the anterior lateral ligaments, so putting in T-LIF and releasing the ALL and really getting it to pop open like a true Smith Pete and fulcruming it over a T-LIF and you get 35 degrees out of that. It's interesting because it's a much easier procedure. And somebody's got a vacuum disc or somebody we can just sort of tear the ALL. And somebody with a healthy disc, that's really hard to get that to really release.
Great. Well, thank you guys. I'm honored to be here, and I guess I give my swan song talk tomorrow. But it's been fun, and it's great to interact with so many bright and curious people. So thank you all for having me.